Okay, I'll call the meeting to order. Start establishment of quorum. Ryan, do you want to start us off?
Ryan Burks, public member.
You got to push for the, make it red.
Greg Lippy, public member.
Debbie Veal, professional member.
Amy Gutierrez, professional member.
Victor Law, professional member.
Stan Weiser, professional member.
Lavanza Butler, professional member.
Alan Shad, professional member.
Okay, due to some time constraints, we're going to go into closed session, and we are going to be discussing Santa Clara County Superior Court case number 16. It's DFEH versus California Board of Pharmacy. As soon as the closed session is over, we'll go back into open session and back on the agenda. I don't anticipate, you think what, about 30 minutes or so, or less? Yeah. So we'll go ahead and open up right afterwards. Okay, we're back on open session. Item number 2, public comments for items that are not on the agenda or agenda items for future meetings. If anyone has an item, if they could come up to the microphone. Good morning.
I am very disappointed that when you opened the meeting, you should have had this item now before you went to closed session. According to the agenda, your closed session was supposed to be at the end of the meeting, and the public has the right to speak before you even went to that closed session. So in the future, please follow the Brown Act.
Thank you
Or
for
the
your
Backley Act.
Thank you for your comment. Any other public items? Yes? Good morning.
Good morning. Eddie Abedikian from Providence Health and Services. Our directors met last month, and one of the items that was discussed was replacing the word expiration on our inpatient medication labels with a phrase or word that is easier understood as we prepare for the 2017 compounding regulations. Part of that discussion and brainstorming was to use the phrase, "do not start after." In preparation for 2017, we decided to be proactive and reach out to Board of Pharmacy inspectors, at least the inspectors that each of us had contacts with, to get a guidance or direction if that phrase would be acceptable. Needless to say, we didn't get a straight answer, and the answers that we received basically recited the regulations. One inspector who happened to be at one of our facilities, in passing, verbally said that that would be an acceptable phrase to use. Again, thinking along the lines of making patient care, as well as nursing education, streamlined and easy. So having said that, and not having anything on paper or formally documented, I guess the question on behalf of Providence Health and Services is, if we replace the word expiration on our inpatient medication labels with the phrase, "do not start after," does that seem acceptable by the Board of Pharmacy?
So Eddie, I think what we'll do is maybe refer this to the Enforcement Committee, sterile compounding, for a discussion. Since this item isn't agendized, we can't have a discussion today about it, but we can certainly refer it that a meeting is in the beginning of January, so just a few weeks away.
Thank you. That would be very acceptable.
And we'll certainly discuss it then.
And if we could have some documentation for what type of product this is going to go on. Is this going to be just for compounded
All
products?
inpatient medication labels that are affixed to medications.
Tablets, everything.
Correct. And again, just to be clear, maybe I didn't say it in the beginning, we're talking about the term BUD, beyond use date. I'm sure you guys would all agree that teaching nurses what BUD meant and having them understand, and new grads and new hires, is very challenging. So using terminology that's very easy to understand, such as "do not start after," would be very beneficial to all parties involved in healthcare. So again, this is more of a, like Amy said, we would love to have some direction, and we don't need an answer today, but it would be great if the Board of Pharmacy could help maybe answer that question.
I think part of it's due to the fact that you do have some infusions that you can, as long as you start it, you don't have to fully infuse it, but they're still okay to be able to give. So I think that's where the confusion lies.
I'm not quite sure this has to come to the board. I think this can probably be a meeting between the executive director and the member, unless a regulation that says the word expiration has to be used on the label.
Well, there are various ways. What I would ask is that we're in the process now of finalizing the enforcement agenda. Can you give me a page or two of exactly some examples of what you would like to see, and where, if you see it as an impediment in the law to get at
Sure.
Mr. Brooks's statement, then we can use that. But the timing's real critical right now because we're just getting ready to finalize the agenda.
Not a problem. Yeah, I could send
All
you.
right, so do you have my email address? Do you
I
know how
do.
to get a hold of me? All right, perfect, thank
Yeah, I
you.
just
Thank you.
had a question, just to clarify. You kind of referenced compound, but did you say this is all things? Did you also say tablets, capsules?
All inpatient medications that are dispensed from the main pharmacy have medication labels affixed to them.
Okay, just want to make sure that, but probably what you give Ms. Harrell will be.
Yeah.
Thank you.
Thank you
Thank
very
you.
much.
Thank you. Any other public comments? Okay, we'll move on to agenda item 3, discussion and consideration of proposed regulations to amend and add Title 16, CCR Section 1702, 1702.1, 1702.2, and .5 related to renewal requirements. At the July 2013 board meeting, the board approved proposed text to amend and/or add these titles related to standardized reporting of convictions and disciplines at the time of renewal for pharmacists, pharmacy techs, and designated representatives, as well as non-resident wholesalers and non-resident pharmacies, with the focus on reporting disciplinary action by other entities at the time these licensees renew. The 45-day comment period began on August 12, 2016, and ended on September 26th of the same year, and the board received a few comments which are attached to the agenda. At the October 2016 board meeting, the board approved a modified text to address concerns expressed by stakeholders and initiated a 15-day comment period. That comment period began on October 27th and ended on November 11th, 2016. The board received no comments during the 15-day comment period. So at this meeting, the board will have the opportunity to discuss the regulation and formally adopt the regulation as noticed for comment on October 27th, 2016. A copy of the text is attached to this agenda item. Board members?
Madam President,
Yes.
I would make a motion that we adopt the regulation language as noticed on the 27th of October and delegate to the executive officer the authority to make technical or non-substantive changes as may be required by the Office of Administrative Law or the Department of Consumer Affairs to complete the rulemaking file.
Second.
Second was over here. Cheryl? Okay. Public comment. Okay, all those in favor? Raise your hand. Okay, unanimous. Moving on to item 4, discussion and consideration of proposed regulation to add 16 CCR Section 1715.65 related to inventory reconciliation report of controlled substances. At the July 2016 board meeting, the board approved a proposed text to add this section related to inventory reconciliation reporting. The 45-day comment period began on September 16th, 2016, and ended on October 31st, 2016. The board received several comments during the comment period, which are attached to this agenda item. At this meeting, the board will have the opportunity to discuss the regulation, the comments received, and determine what course of action we wish to pursue. Among our options are adopt the regulation as approved at the July 2016 board meeting, or amend the regulation to address the concerns expressed by stakeholders and notice the modified text for a 15-day comment period. So there's a copy of the text attached. And in reviewing the comments, Ginny and Ann, I think the one that we actually are, in terms of staff recommendation that we're actually considering adding was in relation to 1715.65E, which basically states that a countersignator is not required if the pharmacist in charge personally completed the inventory reconciliation director. Now, I'm not sure about that phrase, professional director.
That's the person that's responsible in a
Clinic.
setting.
Oh, okay, that, I got it, all right. So then that is, actually is a good one. If they're actually doing it themselves, they shouldn't need to countersign it. Other than that, the staff's recommending rejecting the other comments.
Yes, in general,
There's
yes.
one rewrite.
There are some, there were some opportunities to maybe improve the language a little bit as well, and so that's included in the draft. Some consideration of changes in the language is included in there as well in text.
Okay, so in D, a pharmacy or clinic shall report in writing. So we're saying shall be identified in writing and reported, so there's just some grammatical changes?
Yes.
Yes.
Trying to improve
It's a little
just
more
the
the clarity.
content.
Okay.
And without referring back to the DEA regs, which are actually, the loss reports are actually in a different section, so we shouldn't have to repeat all the requirements.
Okay, so the copy of this modified text is in here as well. Greg, did you have a comment? Any board member comments?
I have another motion if you'd like it, Madam President.
Yes,
Mine.
please, Stan.
So, I would make the motion to amend the regulation language as recommended by staff and to address the concerns expressed by stakeholders and notice the modified text for a 15-day comment period.
And when you say modified by stakeholder, you're referring to the co-signature
Right.
clause that I presented? Other than that, we're going to agree with rejecting the comments that the
Right,
staff recommended.
although it gives staff the flexibility to make language and grammatical changes.
There's actually proposed language in the
Right.
file.
So I just want to be very clear, because it looks to me like the staff recommended modified text stated 12.2 does not reflect the change from the table that you're talking about. So you would be approving this version, that's the December 2nd version.
Right.
In addition, the
addition
language
to
that
the
clarifies the issue about the counter
And
signature.
just above it, it talks about the December 2nd version.
Is that your motion? Stan?
Yes.
Okay, so
So when I look at the December 2nd and I look in item F, I think it does say, or professional director of a clinic. That's the change, right?
Yes, but D
But
was
we-
also rewritten.
But we also rewrote, because we say that it doesn't have to be countersigned if the PIC themselves is doing
Oh, I see.
so that's the change, because what are you going to do, countersign
Okay.
yourself?
Right, gotcha.
Okay, so there's a motion, Greg, second? Public comment? Good morning, Steve.
Good morning, Steve Gray, Kaiser Permanente. Just want to point out there's a slight typographical error too. One of the, I forget which section it is, but you crossed out a whole subsection, like E or something, but you left in front of that the word "and." So
Yeah,
be sure
I
and
saw that,
correct that.
yeah.
And then just to take the privilege of commenting, after this is adopted, there may need to be some clarification with staff and the pharmacist about whether a perpetual manually maintained inventory is adequate. In other words, there's a big difference between EDI, electronic data interchange, automatically implemented inventory adjustments from the supplier, where it goes directly to the pharmacy's computer system and changes what should be in stock, versus somebody who's getting stock in the back door and goes into a three-wing binder and changes what they've received. In other words, it's been, a couple of the inspectors have said that a manual perpetual inventory does not satisfy this regulation because it can still be manipulated by whoever received the product in the back door. EDI, electronic data interchange, in the supply industry sends a notice of shipment ahead of time. And so that there's no chance for the stock clerk to manipulate the perpetual inventory by just not entering what was received and then diverting it. So I think it's a point of clarification. I guess the question is a manually kept perpetual inventory satisfy the needs? The comments from staff were that they did. So that may or may not be what the board's policy is.
Wouldn't a manual inventory also take into account packing slips and reports from the wholesaler of drugs that have come in? So regardless of whether they put it in or not, you still could get a report from the wholesaler on your ends.
I agree with you. It could. I guess the question was, since there's still depending on where and how the manually kept perpetual inventory is documented, there's still chance for manipulation by staff. So I know I saw some heads nod at the board as I was speaking. Those that understand the national standards on EDI, electronic data interchange, along the supply chain will understand what I mean when I talk about, I think it's a transaction 645 or something, that sends an advanced shipping notice that goes directly into the system. So I just think that when I read what staff said, that a manual inventory, perpetual inventory satisfies the need, I don't know whether they understood the difference between a manually kept perpetual inventory and a computer automated inventory.
Thank you.
Okay.
Any other public comments? Good morning.
Good morning. I'm Mark Johnston, a licensed pharmacist here in California. Many of you know me from NABP. I'm District 7's Executive Committee member, a position I was elected to when I was the Executive Director of the Idaho Board of Pharmacy. But I'm not here representing NABP today. I currently work for CVS Health. I'm a Senior Director of Regulatory Affairs. And I stand in support of written comments that Lauren Burton had submitted. They are much the same as what Steve had just requested. Clarification if our perpetual inventory system would satisfy the requirements of this rule. Our perpetual inventory system does use EDI logic, as Steve explained. There's no way for a technician at the store to enter a phantom invoice or even a correct invoice. Everything is fed in electronically that comes directly from the wholesalers through the corporate office and then is accepted in once the order arrives at the store and of course is verified for accuracy. And then on the other end, every dispersal is taking off of that perpetual inventory. Of course, the largest dispersal will be a dispensing. And at the time of dispensing, the on-hand quantity is checked, it's back counted and verified. So it is a true ongoing perpetual inventory. There's a second component to the perpetual inventory, that is the corporate offices force down C2s to be counted and to be verified against the on-hand quantity. So there's two components working together. If there's any variance that's discovered, an investigation ensues. The likely causes will be entered in, such as returns or recalls or an ingredient that might have been used in a compound, etc. Certainly if there's any variance that's unexplained, it would be reported immediately to the Board of Pharmacy. We believe that this system continuously supports the board's concept of strict control over the C2 drugs in the pharmacy. What it doesn't necessarily comply with is portions of the language of the proposed rule that mandate that on top of this continual system, every 90 days an event happens where everything that has been done for 90 days is duplicated, a report is created, and it is signed. So we are requesting confirmation that the perpetual inventory system is compliant with the rule because it was unclear from the staff's comments in the agenda materials.
In the perpetual inventory system you're describing, there's a physical count that's also performed as part of the perpetual inventory transaction?
Yes, correct. So two components. Every time a prescription is dispensed, there's a physical count of what's left in the pharmacy and reconciled at that point. And every drug is systematically sent down to the store to also, I'll say randomly, but there's a lot more logic than random to it, so that without a dispensing, every drug is also counted on the shelf and reconciled to the perpetual inventory.
And that happens at least once every quarter?
At least once every quarter. It is dependent upon volume, both of the store, of the individual drug within the store, and for the most part, it happens every 60 days. In busy stores, it'll happen every 30 days. Certainly every 90 days, every drug is touched.
Yeah, I think that wouldn't that I mean, perpetual inventory, if you're doing it at least every quarter, you're doing it much more often than every quarter. I would think that would be,
Physical count, that's really.
well, he's just described that a physical count does happen at least every quarter.
quarter,
Yeah,
yeah.
on all C2 drugs.
Yeah, there just isn't one report to print and to sign that's required every 90 days, so it's the last clause in the rule. I could break out the rule and quote it for you, but it's the last clause that says, once this is performed, it makes it seem like it's a singular event, and this
Or a report
ongoing
they're
system
looking
isn't
for.
compliant. So, but if I understand correctly, that the system I described would be deemed compliant?
We have to review it.
We'll have one of the supervising inspectors in the room get back to you, Mark. I don't want to sit here and just give you
Yeah.
an off-the-cuff remark right now, but we'll give you an answer.
The whole goal for the regulation is for when the board reviews, when thousands of tablets have disappeared and there hasn't been any inventory except for the biennial. 2 years have gone by and you've allowed a theft to go on for multiple months. This is an attempt to try to have pharmacies at least validate and make sure that they are tracking their C2s.
Understood. Thank you, Jenny. I'll be in touch. Thank you.
I bet.
Thank you. Any other public comments? Okay, we have a motion and a second. Does this mean we also open up for 15-day, Laura?
Yes.
Okay. All in favor? Okay, thank you. Moving on to item 5, discussion and consideration of proposed regulation to amend 16 CCR Section 1735.2 and 1751 related to the compounding self-assessment form. On August 31st of this year, the Enforcement and Compounding Committee, at the Enforcement and Compounding meeting, the committee reviewed and discussed a new compounding self-assessment form that would reflect new regulation requirements and new compounding law that was enacted since the last iteration of the compounding self-assessment form. The proposed new form includes the new compounding regulation components that take into effect January 1st of this coming year. At the October 2016 board meeting, the meeting agenda inadvertently did not include the compounding self-assessment form. So the board could not consider the self-assessment form when it reviewed and moved to public notice, the self-assessment forms that were released for pharmacies and wholesalers. So at this meeting, the board is asked to motion and move to the initial 45-day notice period, the compounding self-assessment form that's provided in attachment 3. Public comment.
I have a question.
Yes, Victor.
On page 2 of the assessment form, where the pharmacist and intern initials and expiration date, there is RPH, there is APH, there's APP. I mean, what?
Okay. The APH is the Advanced Practice Pharmacist number, and on the second line, that's a mistake. That should be APH too.
So it's all APH, not
Yeah,
APP.
yeah. APP can also mean application in our system, and that's a problem, so we will correct that. Thank you.
To avoid
It's the prefix
confusion.
on the license for those of you that aren't aware. And that was one general announcement we didn't make.
That's right.
Whoa.
Okay, hearing no public comments, all in favor? Okay, moving on to item 6, discussion and consideration on proposed regulation to amend 16 CCR 1793.5 related to the pharmacy technician application. Business and Profession Code 4202 establishes the requirements for licensure as a pharmacy tech. There's also in 1793.5, their application requirements for licensure as a pharmacy tech, and incorporates by reference the application form. Earlier this year, 4202 was amended to modify one of the pathways, which is a certification pathway for pharmacy technician. This amendment takes into effect January 1st, 2017. At the October board meeting, the board took action to accept either certification by PTCB or certification by EXCPT to satisfy the license requirement. Because the board's application form requires updating to incorporate the change, a second regulation must be amended. Attachment 4 is a draft regulation language and application form. Staff recommends that the board review the proposed amended language and application form and approve the proposal and initiate a rulemaking. And there is some draft language that is listed below. Approve the draft regulation language to section 1793.5 and the application incorporated by reference to initiate the rulemaking process. Delegated authority of the executive officer to make clarifying changes consistent with the board's policy direction upon recommendations by control agencies. And a copy of 1793.5 is attached. So move, Victor. Second?
Second.
Second, Stan. Public comment. All in favor? Okay, moving on to item 7. Victor, do you want to take this one?
Okay, item 7, stakeholder summit discussion on implementation of Section 1557 of the Affordable Care Act regarding non-discrimination in health programs and activities, especially including its impact on pharmacy translation and interpretations. Let me give you a little overview here. The relevant provision of the Section 1557 implementation rule require covered entities, for example pharmacies, to take reasonable steps to provide meaningful access to individuals with LEP, which is limited efficiency in English proficiency. Reasonable steps may include providing language assistance services, such as oral language assistance or written translations. The rule specifically requires covered entities to post 3 types of publications: a notice of non-discrimination, a non-discrimination statement, or a tagline. A tagline is a short statement written in non-English language, indicating that language assistance services are available at no cost. A cursory review indicates that the federal rule has a limited impact on existing pharmacy laws and statutes. Now, the key issues for the board concerns would appear to be the taglines, which resemble the point-to-your-language requirements in CCR Section 1707.6c. CCR Section 1707.6c requires point-to-your-language text to be printed in 12 specific languages: Arabic, Armenian, Cambodian, Cantonese, Farsi, Hmong, Korean, Mandarin, Russian, Spanish, Tagalog, and Vietnamese. The Section 1557 rule requires that taglines be provided in the top 15 languages spoken in the state by people with LEP. In California, those languages are Spanish, Chinese, Vietnamese, Tagalog, Korean, Armenians, Persian, Russian, Japanese, Arabic, Punjabi, Mongol or Cambodian, Hmong, Hindi, and Thai. 2 subsections, CCR Section 1707.5, regarding patient-centered labels, which include wording languages on matters that does not appear in the federal rule. 1707.5b requires the board to translate labels directions into 5 languages, but does not specify which languages. The new federal rule appears silent on this matter. And on 1707.5d requires pharmacies to provide language assistance with label information for patients with LEP. However, 1707.5d does not specify which languages nor how many languages must be provided. The federal rule appears silent on this matter also. And a copy of the federal rule and relevant pharmacy law is included in attachment 5. Is there any public comment? Any board members comment on this? Yes.
CCR Section 1707.6c requires the point to language text to be printed in 12
Right.
Section 1557 requires 15 languages.
Mm.
Which one are we going to be subject?
So,
We'll go with the federal.
can I?
Okay, I guess this one's coming my way.
What-
Well, Laura, you want to go for it?
Sure. I think the federal rule would supersede for for those covered entities that fall into the regulations purview. So if you read the regulation text, it looks like pharmacies that have 15 or more employees and receive federal funding, I think, would qualify, which sounds like it's pretty much all pharmacies. Is that a pretty reasonable account? But federal preemption would take over where it applied.
And
So
this
they
is-
would have to comply with the
This
federal
is part
rule.
of
We
what,
adjust ours up to 15?
well, that's part of the point of this agenda item, so that we can discuss this, and there may be some people in the audience that wish to speak on this. We were hoping to have some additional speakers. Apparently, this was a bad day to try to get speakers to speak on this topic, so we're going to have to, I would suggest this go back to the Public Ed Committee, because what we want is a single standard of care in the state. Not one for those that are taking care of federally funded patients, but for all patients. And we've gone so far into the translations and interpretation business here that we need to make sure our requirements are consistent with the federal standards. So I think at the very least, we need to modify the point to your language poster to include the tagline phrasing and then go to 15 languages, in which case then we've simplified.
Can I just ask a question? If this is a federal requirement and it's going to be required of most pharmacies that do, why do we need to duplicate that? Doesn't the federal requirement just supersede this?
Well, it wouldn't necessarily apply to those pharmacies that aren't covered.
That are what?
So that are not
Don't-
covered. So
Under 15.
So
Under 50
non-Medi-Cal
employees, no federal
pharmacies?
funding.
15 or fewer and not accepting federal funding.
But there's also some
So who's
additional
not
questions.
accepting
The
federal?
language is a little ambiguous about exactly what's required and when. And so the Office of Civil Rights has speakers that go out to do presentations. We tried very hard to get one in here today. We were unable to, due to the holidays, we were told that isn't going to happen today. So we want to clarify this so that there's a single standard. And Amy, what we would want to do is to remove an impediment that conflicts with federal law, so there isn't confusion, so that you don't read our law book, hit the 12 languages and say, this is the poster we need. Instead, when the requirements federally require, we can at least say, this is the standard we're going to use.
So do we need to change 17076C? But probably the other two, we don't need to touch.
I believe that that's where Laura and I are standing right now based on our review, but I think we need to do a little more research, and we need to hear from some of the entities in the room, because we know many of them have already become compliant. The requirement kicked in, I believe, in October.
And the other question I have is on 1557, it says Chinese, and I think we did Cantonese and Mandarin, so does that mean you choose which Chinese dialect? Because it's kind of interesting, because Cambodian, it specifies
This isn't
the
a good
dialect.
topic to bring up.
Debbie,
Tell us about
in the
that.
Chinese writing, the writings, they're exactly the same, only the pronunciations are different. So
Oh,
if
I
you
did not
write
know
down
that.
the same written language, both the Chinese, the Cantonese speaking and the Mandarin speaking people will understand.
Okay, thank you.
So is it
A little
best
smarter
to
today.
refer this to communication of public ed, or is it
Yes.
something we can handle now?
I think that out of an abundance of caution, that we wait. See, I'm starting to sound like the FDA, aren't I? I suggest that we take it back to the Public Ed Committee, which is where we were going to do it, then we canceled that meeting, so we rolled it here. Now we're going to roll it back.
Do you need a motion to do that?
I don't think so.
Do we have any, so do we have any presentations or public
I don't know if
comment?
there are people here. I think we need to open it up.
Let's open it up and see. Any other board member comments?
So when we're translating, do we require? When we're translating, do we require a certain standard, a certain program that does translations?
There's requirements now for translation.
No, you mean, no, it's just whatever the, you just have to meet the requirement, but we don't require a specific software program or whatever.
Yeah, but the Fed's not required. translate, I mean, this whole thing,
There's a piece that may require translations.
Yeah.
But to answer, oh, I thought I was still on. Victor and I are having a great time pushing the red button here on and off, for those of you that don't know what's going on here. We had a statutory modification that took effect a year ago. And that modification allowed a pharmacy to do translations if they wished, or that when appropriate, they could use our translations that we have in 5 languages that have been vetted. And there are 15 directions for use that we had translated into 5 languages. Those are on our website. So we encourage the use of those if they're appropriate. If a pharmacy doesn't want to use those, they can use a translation of their own making, but we do not recommend a particular type of translation service. It's open to whatever they wish to use.
I just have some issues, and we can probably talk about it at, in committee, of the type of software that's used. I mean, if you go to the Google Translate, it's going to be wrong, you know, and our goal is to protect the patient's health, and I have a fear someone's going to use a similar type of software and get it wrong, and then harm will happen to the patient.
The other issue, Ryan, at least in my experience, what I found is that the translation companies that offer the translation will not take liability for their translation. So they basically say, you pass it through our system, you have to review it. So if I have a pharmacist that's reviewing something in Chinese and they don't read Chinese, it's very difficult for them to do that. We're trusting really a translation company. So you make a very good point.
well, and our agenda item number 7.
Better than no translation.
On agenda item number 7, it speaks about this and what the requirements are for translations and translators and.
Yeah, but as Mr. Brooks says, there is a concern that if you go straight to an online translation service where you're picking up a word at a time, for example, you can end up with a so-called translation that is flawed.
But I thought that this doesn't endorse that.
It doesn't endorse that, but I think it was a reemphasis of concern that we had at the Public Ed
Okay.
Committee discussions that we've had over the preceding couple of years about what can happen if you do go with a straight
Right.
word-for-word translation
Right.
using online language services.
Can I just ask something just maybe controversial, but given the fact that the federal language is out there, do we really need our state regs anymore?
I don't, well, we still have, I don't know. That's something for the board to consider.
You mean
That's a
about,
very good point.
Those that don't fall
Yeah, but
under
I mean, how
federal.
many are not, this is basically taking federal funding, which means anyone who receives Medicaid or Medicare Part D. I mean, I can't even imagine how many pharmacies really fall into that. Oh,
not many, but I mean, I think we can't, I think that it's very small, but I think that there potentially are, so, I don't know, maybe we can't have the.
I mean, just do like a review of our regs versus a federal, see what the gap is there, and then
Which I
maybe
think this
address
is.
that. Yeah, and just keep the federal regs as the standard and eliminate our regs that actually duplicate what the federal government's already done. I mean, just an idea I'm throwing out there. Yeah, we have a lot on our plates that are public protection.
I mean, couldn't we, I mean, really, the only issue is 1707.6C and the difference in the languages, so wouldn't it be a modification of 1707.6C?
Yeah, but then the other regs that actually talk about, do we need to have all of them still exist?
I think the board needs to maybe start discussing that, if that's what you wish to do. There are some other requirements in the patient-centered regs that are different and go beyond the translations and the interpretations, but that isn't what you're asking.
No, I'm asking about the duplicate.
Yeah.
So maybe we do, I mean, I want to hear what the stakeholders and everything says, but I think also, Jenny, maybe at the next public ed meeting, if you can kind of give us a review of where.
The requirement is?
Yeah.
Yeah.
And then the public ed committee can kind of go through it and figure out, make a recommendation back to the
Yeah.
board.
So might I ask one more question, though? Regarding the changing views about the Accountable Care Act that are expected in the immediate future with a new administration, are we in flux here, or, you know, or where are we with regards to this in the event that there would be substantial changes made to the Accountable Care Act?
Well, part of your question, I think, is unanswerable at this point. But I think that if we start taking a look at our requirements and whether or not they duplicate federal standards, that's going to take us 1 or 2 meetings. And during that time, especially if they're on the fast track to repeal or modify the ACA federally, maybe we'll have some kind of sense of what we should do as that evolves. I don't think there's anyone that can answer it now.
Yeah, okay. I just didn't want us to do a bunch of stuff. And
I hear you.
Anyway, is there any public comments on this topic? Any presentations from people? All right, Steve, come on up.
Steve Gray from Kaiser Permanente. We support taking this back to the committee and having further discussion. There's a lot of nuance or unanswered questions here, not only related to the federal law, but you'll simultaneously need to refer to, again, to state law to see what they're going to do over on the non-pharmacy side. For an example, one of the things that was mentioned was the definition of a covered entity. Is the covered entity, as was stated, a pharmacy that has 15 or more employees, or is the covered entity the organization that owns and operates the pharmacy that has 15 or more employees? So you can have a lot of pharmacies that only have 5 or 10 employees, but they may be owned and operated by a corporation that altogether certainly has more. So, you know, that's just, again, a subtlety. Second, in the document supplied in the thing, it talks about and I would refer to, and I can't even remember, I don't think there's page numbers on this, I apply, but it talks about covered entities are prohibited from using low-quality video interaction and from using unqualified translators and interpreters. And what does that mean? I believe in some of the other California law, it talks about what a qualified translator is, and there are certain standards that have to be met. So, you know, that needs to have a discussion. And then just to comment on, we've had people come to this Board of Pharmacy on previous occasions and say they're cash only. So there are pharmacies out there that, some of the compounding pharmacies and others that are cash only. So there are pharmacies that would not fall under this from the fact that you could argue they don't receive anything from the federal government other than the printed money that the federal government prints. So
I think we're interested in the ones that are cash only.
Yeah,
for other reasons. For other reasons.
So again, just to summarize, we support taking it back to the appropriate committees and having more discussion, and then maybe by then there will be other interpretations that will help give us guidance as to what the law is or still is, and all of that. Thank you.
Thank you, Steve. Any other public comments? Well, actually, this is part of the agenda on the public.
Yeah, can I ask, Victor, can we just take this back to Communication and Public Eds, flesh this out, and see what the recommendations are from the committee, and bring it back to the board?
Great idea.
And, in the packet was this thing called Summary of Best Practices. I think that might be one of the things that the public ed, yeah, as well as the review of the regs where this may be impacted.
Okay, that's it, Madam President.
Thank you, Victor. All right, I think item 8, we don't have the individual here that's going to speak on that.
Not yet.
The ambulatory restocking, automated drug delivery systems in ambulances. So then the next item is closed session. So we're going to go into closed session, and if the individual comes, we'll bring back to open session. Is that what we're going to do?
Do we want to ask if there's any comments from those people that are here? Because in the event this kind of closes out the board meeting publicly.
The automated, the ambulances?
Mm-hmm.
So maybe you can give an overview of what the issue is so that we can get some public comment.
I just have curiosity, are we in communication with this individual? Do we know about when?
Well, we told him, I think Jenny told him 1:30, and we are kind of way ahead of time, so
Is there a way to get a hold of him?
I just tried texting him.
Amy tried. I would like to allow Desiree Kellogg to start frame the discussion. She is prepared to talk a little bit about what this is.
So she's going to provide the background and everything?
Yeah, I'll probably amplify a little bit because she's been very brief.
You always amplify.
Thank you.
I'm not sure what that means, but okay.
California pharmacy law currently allows for one method of distributing medications to approved service providers within emergency medical services systems. Pursuant to Business and Professions Code Section 4119B, a pharmacy may furnish dangerous drugs or devices to ambulances within an emergency medical services system in accordance with the policies and procedures of the local emergency medical services agency. So that's one way. There are federal bills that are pending to amend the Controlled Substances Act to provide for the distribution of controlled substances to emergency medical services agencies. Today, the board is asked to consider securing the enactment of yet another statutory or regulatory option for the distribution of dangerous drugs and devices to emergency medical services systems.
Now, 4119, just for my
Wait, I
clarification.
think, Caesar,
Oh. That's right. My understanding of 4119 is related to how a pharmacy may dispense drugs to an emergency medical services
That's correct.
agency. Okay, so it's from a pharmacy, but it doesn't address a physician or any other avenue for them to receive directly from a wholesaler.
That's correct.
I have a couple of questions about this. Nobody wants to minimize the job that an EMT does or any emergency service personnel. But, we're always so very concerned about the education that medical personnel have or don't have when they're dealing with either controlled drugs or prescription items, or which controlled drugs are as well. So I'm not opposed to this, but it's a whole group of people that I have no idea, what their training and background is when it comes to drugs. Now, this may be the horse is already out of the barn, or out of the because they're already dispensing them and getting them, but before we broaden the availability, I would like to learn more about their background and what their education is.
Again, part of it, they already have the access and they already have the
Well,
availability.
that's what I mean about the horse being out of
Yeah, I think the issue is how do the drugs get out there and how are they controlled when they're out into, and I guess I can tell, Clayton Kazan is the speaker. He's from LA County Fire Department, who's going to come speak. And I've discussed it with him, as has Jenny. And I think the request is that at the current time, there is no way for them to have automated dispensing cabinets per the statute in fire departments or in a way that's not in a pharmacy. So I think the request that he's going to make is to allow the board to help sponsor legislation or support legislation that will allow fire departments to have the tools to control drug inventory in the fire department and in the EMS ambulances, because right now they don't have that ability. So all they can really do is store it. I mean, they can store it in a safe, they store it in a controlled cabinet, but they don't have the ability to install automated dispensing cabinets to help track and control. And as you know, these cabinets can help you know where how the drug moves, where it's gone. They have bio-ID characteristics so that you can actually tell who went in there. So I think that's, and Jenny, maybe you can chime in there, but I think that's the request that's going to be made.
Can I just ask a question real quick before? So from reading kind of the background material, in order for that to happen, we would have to make the main fire station a wholesaler?
We can already do that. There are.
You're not turned on.
Oh. Victor, did you do that?
No, it turns off.
Oh, does it?
Yeah, it does.
I was wondering because it was red just a minute ago. We have some fire departments that supposedly have wholesaler licenses where they buy the drugs centrally under the authority of the medical director. The medical director then uses those drugs to distribute and to replenish ambulances. What they want to do is to allow the system to be a little more operational at the need of the ambulance. So instead of having somebody delivering drugs to an ambulance, it will allow the ambulance to go to in one case, 9 regional fire departments where this machine will be placed, where the wholesale drugs will have been loaded into the machine, and the ambulance can sign, remove the drugs, and then you've got an inventory, you've got the after-hours access or the convenience of that, and you've got the advantage of having a secured system for the replenishing of an ambulance in a manner that would probably be less expensive than what they're doing now. They have been talking about this with us for probably 4 or 5 years. As new options to replenish ambulances occur, they kind of recede back a little bit. But this is a model that one county wants to use, and it's a large dispersed county.
Well, just to clarify, I think there's a lot of counties that are using that model.
Rumor has it.
There are a lot of counties using that model. This is the only county that's actually come up and asked for, has actually disclosed and, gone under the hood to show that.
Wants the statute to be
And
that.
I think just to clarify, the way that the automated systems work is there is a central brain that can be held at the warehouse that
Right.
basically says, here's the hub, then all of the different cabinets are connected to that brain so it can manage and monitor. So I think the idea is to put that brain, and I don't want to use trade names, so I'm being very specific, but it's a controlled safe that basically monitors all the outlying satellite cabinets.
And then each ambulance has its own ID, so if I take it from Fire Station 1, because that's where I am today, and tomorrow that ambulance is at by Fire Station 5,
And
it
it's,
knows.
well, it's all bio ID, so you would have to use your
So it's by the
thumbprint.
Your
person?
EMS,
Yeah.
the EMS people, and there'd be 2 signatures so that you have a double accountability to when there's been a removal. So you've got,
So like, if there's 2 people off the ambulance has
Right.
to do their bio, so you know
Yeah.
that was taken off and it was put on that
Well,
ambulance.
if the policy has it that way.
yeah,
But
but it doesn't have to be that
But I
specific
want to
in the
clarify,
law.
and to Stan's point, this is not something that's already happening. The problem is it's not automated. So this process, if you get into an accident right now on this freeway outside, you're going to be using these drugs if you're in pain. So this is a common practice in most ambulances anyway. The problem is the request is to help provide tools so that the medical director, whose DA license is responsible, can track what's occurring at each of the different locations and can track diversion, can monitor use, can see inappropriate, can document waste.
Yeah, I think it all makes sense. I guess I'm trying to wrap my head around, so a pharmacy can have automated devices. What in this law currently prohibits it to be applied in this situation? So what are we fixing?
I think there's a statute, Desiree, a law that basically says where automated dispensing cabinets can reside.
Yes, that's correct. There's a law about where an automated dispensing machine can be located in a pharmacy, and this wouldn't fit.
That's the problem.
So is that what we would be amending, is the automated dispensing machine statute reg
We would
to
create a
allow for it
statute.
to occur here?
You could do it that way, or you could create a new.
Or create a whole new statute specifically to this class of trade?
Or we could amend the current statute to add in that besides hospitals, clinics, that fall under health and safety code, whatever, that also the fire departments that are part of an EMS or medical service agency could also have these cabinets. That's the
Right.
request.
So what is the responsibility the board has to these providers of controlled drugs with their machines and their printouts? And what is the responsibility that they have to us?
Well, right now, the wholesale, if they use a wholesaler, that's one of our licensees, and a wholesaler can only ship to licensed entities. So shipping from a wholesaler to one of these machines is problematic because it's not in a licensed location where it's a licensed entity.
With oversight.
With oversight. And the LA County's got permutations, in part perhaps because they've been speaking to Dr. Gutierrez about having perhaps a pharmacist manage this at LA County Fire so that they can control the drugs in that manner. But that would be discretionary in terms of how the EMS agency rolls it out. But our concern is if that wholesaler is shipping to an unlicensed location, we've got a beef with what the wholesaler's doing. And that's why we keep getting brought in.
So do we have no concern about the security and about the dispensing?
Personally, based on what's supposedly already going on, it's already out there being done. It's just that the law doesn't authorize it. But no, in a fire department, it would be as secure as, it would be any place else. And keep in mind, these vending machines now, we're starting to see them move away from a pharmacy.
It seems,
I'm
Sorry.
fine.
That's a problem.
Yeah, I'm fine with all of that. I
it
just.
seems like,
just-
Stan,
it-
this
it's-
is,
It seems that we're so focused on the security of these machines in pharmacies and in hospitals and all, and here, firemen are wonderful people and EMTs are wonderful people, but we're allowing these machines with controlled drugs in particular to be in an environment where there's no oversight, and that's
But-
my curiosity.
Well,
But
wait a
there's-
minute,
there's
wait a
no-
minute,
There's
isn't-
no oversight now.
no, wait a minute.
realize
If there's
that.
a wholesaler, there's a designated representative, so there is oversight, right? And then the second thing is, I think this is actually a way to get control on the system, because it seems like, right now, it seems like there isn't a control. We really can't know where things are going. I mean, so I think this is actually a way to
Well, I think
fix the
it's an
system and be
attempt
more
at it.
comfortable. I'm actually more comfortable with what's being proposed than what we currently have.
And just to clarify what's actually happening, and I can just talk about LA County, but currently in LA County, the only way that these providers can resupply is through the county pharmacy. So they actually come and they provide proof that they've used the drug, and then they get replenished on a one-by-one basis. And that's just been set up that way for years, just because of the law that Desiree referenced and the fact that they do need controlled substances. However, the county pharmacy doesn't really have oversight over those narcotics. So because they're not out there, they're not paramedics, they don't oversee the ambulance company. So the DEA, the medical director is going to be taking over responsibility. But he's saying, if I'm going to do this, I would like the tools to be able to know what's happening out there, because he can't from a central location. So the options he has is either give them tackle boxes and have them go out with their medications and do this, or give them the tools, which is the automated cabinets that have bio-ID, waste capability, to be able to track that. And it makes a lot, I agree with Debbie, and I will recognize I'm in a conflict situation being an LA County employee, but having the tools to be able to do this, to me, is a lot safer than having a process where you really don't know what's happening.
Yeah, because it seems like with this, if there's some missing drugs or whatever, which I think, Stan, I think that's really what we're worried about.
Right.
Like, I can't quite see you.
Yeah, I'm sorry.
But, right now, I feel like, I understand where you're coming from, but now I feel like if there were some drugs missing or someone was, using them inappropriately, we would be able to track it with this system, whereas today we probably couldn't. That, it's kind of like, well, she.
It just seems like there should be a supervisor that's, a pharmacist supervisor that can oversee this distribution method.
I think Clayton will tell you when he comes that he's planning on hiring a pharmacist to oversee the process. Once he's able to get the machines.
Yeah,
Like I said, they've been waiting for 4 years, and they want exemptions so that they can do what other departments supposedly are doing. We don't have the authority to grant an exemption. We have no ability to do that. So, and it's not a mandate, it would be an option for them. It would give them another tool, and maybe some counties may never want to use it. But this is something that hasn't gone away. They've been working with the DEA over the years to try to also get a DEA permit so that the machine and the wholesale itself both has to have DEA permits. And DEA has been pretty cooperative in that.
Good.
We're kind of the impediment here, where we won't let them have the machine.
Well, far be it for me to become an impediment.
Public comment?
Public comment.
Steve Gray from Kaiser Permanente. We support going back and having a full discussion on this. There's a lot of things that have kind of evolved over the years, and although 4119, when it was adopted, codified what had already been going on, we need to realize that most of these ambulances are often restocked in the emergency room of our hospitals.
Yeah, they always have been.
You know, they pull up, they say, I just used, 50 liters on somebody. That's a joke. And
Steve, is that still going on? Because I thought there was an issue with the kickback statutes that they could no longer be resupplied.
my understanding is that it is still going on. It may be non-uniform. I mean, that's an easy thing to say, that nothing's ever done the same way. But I think it all needs to be discussed. When you're talking about controlled substances, then you're going to have to bring in a discussion about what the DEA requires. A physician, for an example, who is receiving controlled substances has to have a DEA registration at each location that those DEA controlled substance drugs are stored. And so you need to bring that into and see if these machines that are going to be stored at the fire stations are also going to be registered locations with the DEA, et cetera. So all of that, I think, needs to go back and get fully discussed. But I think that there's, I've heard enough here to say that there are probably a good time to review all of that and look for, not only more efficiencies, but better controls. And then also ask about, it seems that the board members may not be knowledgeable about just what type of drugs we're talking about, because with telehealth things, a lot of things can be and are started in the ambulance or at the site of the emergency that have evolved over the years. And, morphine is a regular component of what an ambulance carries around and what they get restocked on and so forth. So we support going back and taking a good look at but taking a comprehensive look at not only public entities, but the statute, as I understand it, even covers private entities and ambulance services are restocked. So it's not just the fire departments and other things. And it always talks about the local emergency services agency, and personally I don't even know what that is, but you probably need to bring whoever they are or represents them in to have also participate in the discussion. So we want to support this.
I think it would be important also to have the state EMS director involved in these discussions, because this is not, even though LA County is coming up now, I think it's an issue across the whole state. Because there's been a lot of practices that have occurred over the years that may or may not meet the current letter of the law.
Right.
Good morning.
Morning, Mark Chu, Orange County Healthcare. I agree with a few things that Steve said, but also EMS systems and the practices by the EMS system differ by county. So you might put forth some statute or something that's going to interfere with other agencies. So you're going to need to go statewide to get everybody's input. The other thing is that what's written here, you're only addressing ambulances, but there's also paramedic units. And in Orange County, ambulance providers can only give a certain number of drugs. They're restricted. Paramedics can give a few more. And to address your point, it's a limited number of drugs. It's not like the whole gamut. So they only have a limited scope of practice, and they have to stay within that. The EMS director, in our case, he is the one that has the multiple DEA registrations for the sites that have the automatic dispensing machines. And this has been going on, a long time. But it was way back, it was 1999, I think, we started pulling away from getting them restocked from hospitals. So we set up purchasing through different specialized wholesalers for EMS. And they in some cases, they treat the fire department as a physician's office, or physicians or a clinic. So they send it to that office, and the office has the automatic dispensing machines at the fire stations. So it kind of gets around the Board of Pharmacy, and but it's under the physician's purview. The other thing is you had mentioned is that fire departments have limited budgets. So now do they have to hire a pharmacist to oversee all the operations that they're doing? Fortunately for us, I'm part of the county, so I get to kind of oversee what they're doing. So, but again, it's not the same in every county. So you would probably, you would make a requirement where fire departments are going to have to hire on a pharmacist. So that's another issue. And let's see, the other thing is that there are fire stations that already have their own DEA permits because there's a program that the CDC has put out there where they put antidotes out there, which includes diazepam. So they already have DEA registrations at some of these sites. So there's a lot of considerations you're going to have to look at if you're going to push forward with this. And again, I think, I don't know if we've spoken with him about how to set up this system without requiring the board to create new governmental red tape.
Do you know if there's ever been any losses with any of these
Yes.
machines, and who reports to whom?
The medical director does the investigation.
So have there been losses?
There have been a few losses. I've been pulled in on the investigations too.
And so what happens? So there's a loss, and then what happens?
Oh, well, most of the losses that I remember happening were before the automatic dispensing machines. That's why they were put in. So that has actually decreased the losses.
Yeah, but what happens, and I'm not trying to put you on the spot, I'm just trying to understand how it works.
Well-
So if there's a loss, and I don't know, if you have, let's say you have a couple of vials of Demerol that all of a sudden, are unaccounted for, so, or any quantity.
You know what, Stan, what might be helpful, can you just tell us just an overview of how it works on the supply chain with the automated dispensing cabinets, how it goes so that he understands, and then you can go into how you actually identify the losses.
Okay, so the way the system is now, central location orders the drugs, then the
Under the physician's DA number.
Right. And with the EMS wholesaler, they're also using the physician's DEA. So then when it comes to central location, it gets sent out to the automatic dispensing machines and loaded in.
Who delivers those? Who delivers them to the locations?
EMS does. Could be one of the paramedic units picks it up. There's also, in some of our fire stations, there's a supervising nurse. So, and she travels around to different sites too. So then they're restocked, and then each paramedic has his own ID to get the drugs out. So they know who's taken who has taken the drugs out. To answer the question, 2 of them have been fired already because they identified who it was. And so
They were able to track them through the automated cabinet transactions. Do you use BioID?
Pardon?
Do you use BioID?
I don't know if they purchased that one yet, but this was before the BioID was available. So
Thank you.
okay.
Any other public comment? Okay, Dr. Kazan said he'll be here in 30 minutes. What do you want to do? Do you want to take a break or
You want to go to closed
close session and then we can come back in 30 minutes?
Yeah. Sure.
Okay. Okay, we'll go into closed session and then reconvene in about 30 minutes, back into open session to discuss the controlled substance for the emergency medical services request. We're going to go back into open session, and we're going to continue with Agenda 8, which is discussion and consideration of a proposal regarding ambulances restocking medications using automated drug delivery systems. And we had a little bit of a discussion already about this before we went into closed session, but we have Dr. Clayton Kazan here from the LA County Fire Department. Dr. Kazan, you're on.
All right. Thank you very much for inviting me to come and speak. I really, really appreciate it. I want to give you a little bit of background on sort of how we've reached the point that we are right now And just a brief background of what LA County Fire Department is. So in the County of Los Angeles, there are 2 major fire departments, and then there are a bunch of smaller departments. The 2 major departments, there's the City of Los Angeles Fire Department and the County of Los Angeles Fire Department. We cover 4 million people. We cover 58 of the 88 cities that make up LA County, and about 170 fire stations and 2,300 square miles, also including Ocean, Catalina Island, and all the way up to the Kern, Ventura, San Bernardino, and Orange County lines. So very, very large area. About a year ago, and the way we obtain our controlled substances, the ones that we carry in Los Angeles County are morphine and midazolam. The way that we obtain our drugs, and the way we've done it historically for a long time, is that we go and we get our drugs through the county hospital system. From the county hospital system, from the pharmacies, they're then taken out, usually by utility truck drivers, out in a locked bag out to the field units to restock. The system has been fraught with just difficulty. It's slow. It results in such an onerous restock process that our paramedics are really hesitant to give the drugs. So we have a major issue in the way we deal with pain in the county, because in order to give the dose of morphine that they may want to give to a patient with a bad injury, they have to think back in their mind about what it will take to get that vial replaced. And if they get below their par level, then that unit has to go out of service. So we believe it's resulted in a vast undertreatment of pain across the county. Another issue that we've dealt with is that the county hospitals will not dispense fentanyl to us because fentanyl has a higher rate of diversion, even though fentanyl really has become the standard of care for EMS across the country. And the issue for us in LA County is that because morphine is only approved to be given IV, if we have pediatric patients that have a bad injury, the only way we can give them pain management is to start an IV, which for a child is a really terrifying thing to go through. And our paramedics lack a lot of experience at getting IVs in young children. So the end result is children with bad injuries frequently get no pain medication at all. And even if we try to do it, we might poke them multiple times, get no IV, and then provide no pain management, other than maybe a splint or an ice pack. So we really are behind the game in terms of how we manage pain in the county. The only way we're going to know to what extent is if we change our system and measure the usage of morphine before and after the restock process. And I am really confident we're going to see a significant rise in the utilization of morphine. So the timeline is, about a year ago, the county hospital pharmacist, the pharmacy director, came to us and said, we want to get the fire department off of our DEA license. And I think for a lot of good reasons. And they wanted to transition it to my medical license. Unfortunately, our system of restock, while it may meet with current regulations, is such a bad system in terms of being able to really track and be accountable for our drugs that I was unwilling to put my medical license on it. What we suggested was that we need to build the system that we really want to see, which is we need a system that will allow us over such a broad geographic area to be able to really track and keep account of all of our controlled substances. And the way to do that is to do the same thing that the hospitals do, and that is to use automated drug dispensing systems. Because what that would allow us to do is allow our field paramedic units to restock themselves, but allow us from our central hub to know where every vial of drug is throughout the county without having to be present for live restock every time, which is what we are currently doing. So we started working with this process. We met, the major players in EMS met with the county pharmacies and with the DEA back in May or June of this year. And the first hurdle we thought we would see was that the DEA might put a stop to us. So we met with the DEA regulators in the area, and they said their suggestion was that we send a waiver for the Controlled Substances Act to Washington, and they thought it would likely be granted. Well, it took us about 3 months. Back in August, we heard back from the DEA that the waiver request was denied. However, in their denial letter, they also included that there was nothing in current regulation per the DEA that would preclude us from moving forward, and actually they felt that using automated drug dispensing systems made a lot of sense as long as we conform with all of our reporting requirements and tracking requirements, there was nothing in their regulation that would stop us from doing it. The issue we came across, though, was with the state. So with the Board of Pharmacy, for a small department like Beverly Hills that has just a couple of fire stations, they could put one system, an automated system in, and take deliveries directly to that system, not distribute from there, and they would not fall under the purview of the Board of Pharmacy, this is per my understanding. Where we start to fall into trouble, and where LA City Fire is in the same boat, is that we're such a large department, we're looking at the possibility of having about 25 machines. And to track shipments directly to 25 machines becomes such a difficult process that it seems to me to be very, very high risk, that we could lose a shipment, lose a dose, and not be able to account for it. That the way to handle it in a large department is to have a hub and spoke type model, where we would take deliveries to a central hub and then distribute out to our satellite Pyxis machines from the central hub. But in doing that, if we were to distribute more than 5% of our total deliverables out to our satellite Pyxis machines, then we become a drug distributor, and then we fall under the Board of Pharmacy.
Question, could
Yep.
the maker of the drug deliver directly to the machine?
The answer is they could. We could use our wholesaler and have them delivered straight to the machines. The problem is, how do we track well, is it a better system for tracking that drug from our central headquarters to know what deliveries have been received out of the satellites?
But they're all automated.
I think they need a 222 form because it's a DEA controlled substance. So there has to be a chain of custody switch when it becomes under the medical director license versus the wholesaler.
But can you have an electronic chain of custody?
Yeah.
So why does the fire department have to receive it?
How do you know it's correct? I mean, someone would need to validate that those 10 morphine vials actually came in, especially when there's a chain of custody switch.
Well, then send them out to the machine. I mean, why would you have all these drugs come into the fire department? And
Well,
then go back
I think what
out?
he's planning on doing is actually having a machine in the central hub that will actually track it. So it'll be like, if you think of his hub and spoke model, he's going to have a machine where all of it'll control the other machines. And it's actually, and I know, he mentioned the vendor, but it's called the C2 Safe. And it basically controls, it's what we use in a hospital.
Well, how-
Control all the narcotics.
How are you receiving the drugs?
So the plan, what we'd like to do, is we would like to put at our headquarters building, which is a building that is, to get access on the Hill, there's an armed guard, there's cameras, there's badge entry, to put, and I realize this is vendor specific, but to put a C2 safe there and actually hire a pharmacist to help administer the program, receive the deliveries at that one central location, and then be able to basically scan in, scan out medications that are being out delivered to their satellite machines. It just seems to me that if all these drugs are going to be under my medical license, my DA license, that I would like to know where they are, and I'd like to have them all come into the same location.
Why are they moving it to your medical license? Why does it have to be there instead of with the county?
Well, they need a medical practitioner to be able to put a DEA license to it.
What are they using now?
The county pharmacy director's license.
I can answer that. What the issue is that, well, it's under the county pharmacy's license. The same concerns he has about control and oversight also fall into, because if one of these paramedics were to divert drugs, our board would go after that pharmacy in an area where they have no control over what's happening outside the hospital. So because of that risk and the board's regulations, they don't want that responsibility even less. And they have no, and the medical director has a lot more oversight than a pharmacy
So
over what happens.
has the pharmacy board ever had any interaction because of a loss of controlled substances with the LA Fire Department?
I don't know. I don't remember. It wouldn't surprise me if we had.
Well, I understand that, but it has been either so long ago or it hasn't been.
In my background, there has not been any that I'm aware of.
And that's my point. And it was my point before you got here. No offense, but the system, I've always been curious about this system because I've just always been curious about it with regards to all of the meds that wind up in an emergency vehicle used by EMTs and the controls of them. And it seems to me that the system hasn't been ideal when it comes to security and been ideal when it comes to standing up to an audit. The question is what's the oversight? I mean, you know, I'd like to see a plan that says this is going to be the oversight and this is what it's going to be, and this is the person or the agency that's going to suffer the consequences. But right now, it's also kind of fuzzy.
Are you asking, Stan, in relation to the automated proposal, how the oversight's going to be?
We're talking about allowing controlled drugs to go to entities that, in my view, have no oversight. It's great. It's in the fire station on Redlands Boulevard in Citrus in Redlands, California. Great. And the EMT takes what the EMT needs, you know, using their code and everything out of the Pyxis or whatever, and off they go, and they use it, and it comes back. And I'm just not quite sure, you know, where they account for that.
But they already have the drugs. You know, you realize that. We're not asking to introduce a new avenue of getting the drugs. The drugs are already out there. Dr. Kazan says they're being underutilized, but they have access to them.
Well, I say that this is a point for maybe the pharmacy board should look at and say, well, what's going on here? They're coming to us because they need a waiver or something that's going to allow them to continue to do this. I'm fine. Firemen are heroes. Give them what they want. But I would like to see some plan of accountability. So it goes out on one of these EMT. So they give a shot of morphine. Mm-hmm. So it's a 3 cc ampule or a 2 or whatever it is. So if they only give us a cc, what happens to the rest of it?
So,
how's that accountable?
So we do have a system right now. So every vehicle that has its PAR level is inspected every day. Both medics have to sign off on it. All those records are kept at our EMS bureau, which is in Commerce. Whenever morphine is used, if there's waste, the waste is done at the hospital, signed off by the nurse, and all the waste is accounted for with that daily checkoff. So there is a system of accountability right now about who is taking control of the medications at the beginning of every shift, and then who is handling the restock whenever a vial is replaced, that vial is also signed in, and there are forms that track. But the reality is we're working with 1970s, 1980s technology, and there's much better stuff out there that would allow us to be able to track from. So our department's grown exponentially as this whole EMS system has. But our ability to actually track the medications has not followed technology.
Yeah.
So we're still, I mean, think about what the hospitals were doing in the 1970s and what they do now. We're still operating in the 1970s.
Yeah. And I appreciate it. I think what you're doing is good. I just need more of a comfort level about what you're doing.
I'm more than happy to come and present the entire idea. I didn't get it to that level because at this point, it's not something that is allowed in regulation. So, which is the reason I wanted to come and present this idea to you, and I presented it yesterday to a group that I represent, which is the EMS Medical Directors of California, and many, many other systems are in the same boat and looking to do the same thing.
So would this apply not just to paramedics or the fire department? Would this be a system that would be utilized by like AMR?
Potentially, yes.
Yeah. And so, to be honest with you, I mean, no reflection on the company itself, but I think that would cause some heartburn for me, especially them being eligible for the same system that you are proposing with your department, and I would be uncomfortable not knowing what security issues and they would have in place with regards to these controlled drugs.
Are you looking for a waiver for LA County Fire, or are you looking for a change in statute, or are you, I mean, can you kind of explain what?
What you're asking for.
Thank you, Ryan.
Okay.
Or what he said.
So my ask would be a waiver from the board to allow, at least within the county of Los Angeles, so not just LA County Fire, but LA City and the other departments within LA County as well, to proceed using automated drug dispensing systems for better drug accountability. And there's a big shift right now that's going on to move to medical directors' DEA licenses. And honestly, I'm afraid, because I practice clinical medicine as well, and obviously if I lose my DEA license, I might as well look for a new profession.
This could be a pilot project.
Okay.
My question now is, what is the waiver process?
We do not have a waiver because we do not have a law we can waive here. There is no authorization for a fire department to establish a automated drug delivery system.
Can we
And
do,
that's what-
can
and
we do
that's-
a pilot on
Project.
the use of, using that automated dispensing language, where it says it can only be in clinics and hospitals? Can we do a waiver to allow a pilot?
That is a statutory provision, so no, we have the ability to do a pilot study on regulations. The only regulation we have is one that allows a refill dispensing machine to be immediately adjacent to a pharmacy. We have nothing else. That way the pharmacy owns the drugs. We are doing the scripts or the
Right.
Asteris waiver under that regulation with the School of Pharmacy because we have separated that refill machine away from the pharmacy, immediately adjacent to the pharmacy counter, to standalone. But there is nothing to put it in a facility where there's no health care being delivered, which is part of the problem. That is part of the problem they have. And so a waiver will not work, in my opinion, and unless our attorney can come, I've got two attorneys over there.
Right.
It doesn't work.
It doesn't work.
So
We cannot waive anything.
what's the solution?
A trip to the
Is it Board of
legislature.
Pharmacy? Is it going to the legislature?
Yes.
Is
Well-
it creating a new rulemaking process?
There are two federal bills pending right now that might resolve it. There's also, you can amend, some of the statutes that you currently have on automated dispensing use, or you can create your own statute, but there are federal bills pending.
But can you expand upon what the federal bills are that you're referencing?
You can.
So there is a House of Representatives bill, it's HR.
It's okay.
It doesn't matter.
And there's a Senate bill that's 2932, so I've never won.
It's House Bill 4365.
What is it, 4365?
So it's,
Do you know who authored it?
oh, sorry.
Um,
They're proposed amendments to the Controlled Substances Act that would allow EMS departments to store drugs and be able to give the medications on standing orders. It passed the House of Representatives. It did not get through the Senate before they adjourned for the winter break. And so with the change coming next month with the new president and everything, there's not going to be any, the bill's going to have to be reintroduced with the next Congress, unfortunately. We were really hoping it would get through right before the new year, but it's not.
I mean, it still goes back to my question. If this board were to take action to solve the problem, what do we need to do?
You need to develop regulations or amend the regulation.
First, you need to amend the statute.
Statute, yeah.
Regulations are you referencing that we can amend?
Well,
I think Ginny's right. I think we need to amend the statute first to permit the storage or the automated drug delivery device to be somewhere else. But you can also, I mean, I think you're very preliminary, you're at your preliminary stages, and certainly you could build in some of the protections that are being discussed about under what conditions. But
So I guess what I'm hearing is this is the wrong jurisdiction to have this
Can you turn your mic on, Ryan?
That this should go through the
Your mic,
legislature.
Ryan.
So is this the wrong, is the Board of Pharmacy the right place to have this discussion, or should this discussion be had at the legislature?
it would have to, arguably it would happen, have both. My understanding is it's being brought to you because the proposal would be to amend your statutes. So
But in order to
because,
amend the statute, it would have to go through the legislature.
correct.
And they're looking to work with us to secure that legislation, which would allow a pharmacy-based solution to this issue as opposed to one which the federal legislation would create, which is an EMS-based solution.
So what's the likely timeline of this?
I believe if we can draft language, it could be in place by the end of the year, end of 2017. Pardon me? It could be our bill, it could be their bill, it could be a joint bill, it could be an author's bill. I think we need to recognize that I think we have a certain area of technical expertise here, and we need to exercise that, especially given the concerns of the board as we're discussing it, to make sure that the fire department has what it needs to take care of its patients, but yet we can maintain the security of these devices in an area where there isn't health care provided, which is how.
They're
these issues-
asking to hire pharmacists to do this, right?
Right. They've agreed to do that. They volunteered to do this. That may be one of the requirements that we may want to build in if we're going to have this kind of system. And for physicians, that may provide some peace of mind, as
Yeah.
it does to Dr.
I like
Do we
Kazan.
have a draft out?
We don't have.
Do we have draft language?
If you could.
Wait, let's go one at a time.
Do we need a motion to draft?
Before you make a motion, or call for one, I would suggest that the proposal at least go to ledge reg or licensing or somewhere, so that the.
I'm familiar with that.
Are you really?
committee.
So that would be my suggestion.
When are you meeting next?
So that the committee could vet it and look for opportunities to work with you and perhaps, deal with some of the crafting of it and then bring it to the full board for the input from the board.
If that is the direction from this committee, we could do that. We have a ledge reg committee meeting scheduled around the 23rd or the 24th.
What about licensing, Jenny? Isn't there one coming up?
There is also licensing, and that is the 10th.
I think licensing makes more sense.
Well, I didn't want to suggest licensing for the obvious reason.
Oh, well, that is a very obvious.
We both think licensing's great, Stan.
Okay.
But licensing would be fine.
Part of why Dr. Kazan is here, though, is that I agreed to provide technical expertise. If the board wishes us to be involved, I will do a little more aggressive technical expertise. But whether I like it or not, I keep getting brought in, and I keep getting asked to grant waivers that I know I don't have the authority to grant. So with that being said, I want to get out of the hot seat I'm in and at least into some solution mode. Even if we turn the legislation over, we may be able to find, I think we have an author's office that's interested in handling the bill, which is a good thing. So that gets the fire department. At the end of the day, the goal is to make sure that the ambulances can have the medication they need in a most cost-efficient manner possible.
And that
I
there's
don't-
a safe tracking system.
Exactly, and the machines do things that it's not 1970s anymore. There's-
Now, Jenny, I think the other thing is that we have to recognize as well, as we heard this morning, there are other jurisdictions that are already doing this and fully aware. I mean, we just heard one today.
Yep.
So at least LA County's come up and asked for it, but this is happening all throughout the state.
So we need a motion, and Debbie has agreed to make it.
So I
still have a question before the
I
motion.
didn't want to be heard.
So one brief question. Do you already have draft legislation?
Not yet. The committee I met with yesterday, which is my counterparts throughout the state, we just set up a working group to help work with you guys to write legislation.
Gotcha. Okay,
Perfect,
thanks.
thank you.
Okay.
There's one other issue to bring up with this, and that is we have a time crunch too. And that we actually were ordered out by the end of this year. We've gotten a delay back to the middle of 2017, but July 1st, 2017, we're out of the county pharmacies. And unless we have a method of procuring drugs that's safe and reliable, then all of our paramedic functions in LA County would cease.
Just to clarify, the July 1st deadline was to transfer responsibility from the county license, pharmacy license, to the physician DA number. The county pharmacies are willing to continue the process, but they do not no longer want to take responsibility over a process they have no oversight over.
Well, there might be an opportunity for a waiver for a short period of time.
So
There's your waiver.
the problem is,
6 months.
So the motion I was going to make is that we direct staff to, do a deeper dig into, the reg statute that would need to be changed, and then bring it to the next licensing committee, seems like the right place to put it, licensing committee meeting to review and bring recommendations back to the full board, possibly, I guess, when we meet in a month, yeah.
Second.
Any public comment before we take a vote? Dr. Kazan, do you have any comments?
One last comment, and that is, and like you said, the reason that we're here is we want to be open and transparent about what we're doing. But knowing that I would have to take the current process under my DEA license, I'm not willing to do that, because that
Don't
would
blame me.
jeopardize my ability to practice medicine. For the same reasons why the county pharmacy doesn't want to have it anymore either.
Right.
So that we may have to proceed, even though this is really uncharted waters.
We want to help you, and we also, can understand why you wouldn't want it under the current situation.
And I think that Orange
said-
County, didn't you say that that the physician has it under his license in Orange County? That's what they're doing. Okay.
Yeah.
But they have the Pyxis machines.
Right.
With your concern driving a shorter time frame than normally occurs with legislation, I think if we put the first thing first and actually get a bill that people generally can accept and move forward with, that would be a significant thing, and then perhaps you can negotiate with another entity to kind of help provide some of the waiver that you might need for the other 6 months.
I'm not sure, what did you say, Jenny?
I was trying to say gently, let's develop the language, and then if it looks like it's moving through the legislature, negotiate with LA County to see if they can get a reprieve for a short period of time
Right.
on the waiver.
Who from LA County makes that decision? What department?
Waiver for, wait, let me clarify. Makes a decision for what? For what?
July 1st date.
This whole July 1st.
Okay, that means the board would not hold any of the county pharmacies responsible.
Whoa!
Any thefts for 6 months. Okay,
No.
but really, that's what's happening here. Remember, too, that there is one county hospital that we recently voted on, that actually was put on probation because a nurse was stealing drugs. Remember that. That county hospital is on probation right now. They are not supplying to EMS. We had to rechange everything because they couldn't risk the probation this board placed on that hospital. So the other hospitals are saying, look at the risk we're under. We don't want to be held liable by the board for something we have no control. Remember, these are like ambulances that are outside the hospital. They don't have, the whole issue about the waste that Clayton mentioned, we're very concerned about that waste. How do you know that the signatures are nurses that are in other hospitals?
Yeah, so all we can do is the purview within the Board of Pharmacy. It sounds like there might be some housekeeping within LA County, and hands off.
Yes.
I would like to call the question, please.
Okay. Is there, who had the motion?
It was Debbie and Stan.
Stan second. All in favor? Okay, I'm abstaining. Motion passes. I can't, I have a conflict. Thank you, Clayton.
Thank you very much.
Thanks for coming. Okay, we'll go back into closed session to deliberate on the rest of the disciplinary matters. Oh, I need to read off something, right?
Yes, you have to read.
Which is-
Title, there's 3 pieces of litigation. You need to read.
Okay, we're going to be discussing 3 pieces of litigation. The first one is CalMex versus California State Board of Pharmacy, Sacramento Superior Court case number 34-2016-80002456. Crea Caron versus California State Board of Pharmacy, Riverside County Superior Court, Palm Springs Branch, case number PSC 1604591. The third is Melamed versus California State Board of Pharmacy, LA Superior Court, case number SC 126060. Thank you. Closed session.
So do the attendees here receive a full day credit, or they got half a day credit for attending the board meeting?
So, the board is going to recess into closed session. It will adjourn, or come back into open session before it adjourns, but in order to accommodate the timing, all that's left on the agenda is simply to go back into open session and basically adjourn the meeting. So the webcast won't be available after the closed session, and that's included on your agenda. So the public, for purposes of the public, you can come back and watch the board open and then close, and then adjourn the meeting.
And you get it.